that pituitary is by far the most important as far as the endocrine glands are concerned, because it is regulating the entire system. So when we talk about pituitary physiology, we are pretty much talking about the growth hormone physiology, we are talking about the thyroid physiology, the adrenal physiology, and the AVP physiology. So pituitary, of course, is very important. But what is more important than pituitary is the hypothalamus, because hypothalamus is the ultimate controller of pituitary. So when we talk about hypothalamic control, Dr. Manoj, what is the difference in terms of different hormones which are being controlled by the hypothalamus, the level of control, the type of control which happens from hypothalamus with the pituitary?
In relation to pituitary, there is always stimulatory control to the all hormone, rather than the prolactin, which is the inhibitory control, which has the inhibitory control.
So you're saying that all the hormones pretty much are under a stimulatory control, except for prolactin, which is under an inhibitory control. So why do you think there's a difference in that regard? Why is prolactin unique in that perspective?
Because all other hormones should be chronically secreted by the body. So it should be positively, the association should be positive. And in terms of the prolactin, it is only required while the lactation or like in the postpartum period.
So in the evolutionary perspective, prolactin is only one which is required on a timed perspective. That is why you want to suppress it. Rest all hormone you need for a daily purpose. You need ACTH, you need AVP, you need LH, FSH to a certain extent. So that's why you have got a stimulatory pathway in that perspective. But there are also inhibitory signals of other hormones as well. It's not just that you have got just the inhibitory signal for the prolactin. What do you know about the other inhibitory signals for other hormones?
Like somatostatin.
So somatostatin is pretty much inhibiting everything. Somatostatin is inhibiting TSH, it is inhibiting growth hormone, it is inhibiting ACTH. So that's why somatostatin receptor analogs are used to treat a lot of excess conditions like growth hormone excess, like thyrotoxicosis, which is TSH dependent, like even Cushing's disease, which is recurring. So this is somatostatin is one arm. Anything else? Do you think of inhibitory signals?
Feedback inhibition from there.
That is different. So from the hypothalamus. So dopamine coming from neurons is inhibiting prolactin. It is also inhibiting, and that also becomes important. So what we are talking about, what Manoj was trying to say, is the predominant tone. We are not saying that there is no inhibitory signal coming, somatostatin is coming, which is inhibiting the growth hormone, but the predominant signal is GHRH. Somatostatin is responsible for some pulsatility. So when you want it to be high, so it's like a fine tuning. When you are controlling, you want something to go up. You also want something to not allow to go up too much. Therein the somatostatin will come into the picture in that perspective. So this is an important aspect to remember. Now within the pituitary, we of course know that there is anterior and posterior pituitary. So Vibha, what are the major differences in terms of manifestations of anterior and posterior pituitary?
So manifestation, like if there is an anterior pituitary, the level of the prolactin.
So generally speaking, what you're trying to say is that in anterior pituitary and posterior pituitary are two distinct components. They have got different origin. One is neural and one is glandular. The other thing is that their blood supply is different. The nature of their overall process, how much radiosensitivity they have, are different. So which part is more radiosensitive, anterior or posterior? So anterior is more radiosensitive. Anterior is more sensitive for vascular damage. So when you talk about ischemic insults like Sheehan syndrome, mainly the anterior pituitary is affected. And the other big thing is that posterior pituitary is mainly producing two hormones, AVP and oxytocin. So oxytocin, you will not really know the clinical features in that regard, but AVP is actually not being produced by the posterior pituitary. It is produced by the neurons which are there from the supraoptic paraventricular nuclei, which travel the whole process, and which we'll discuss subsequently, that 5% of them terminate in the median eminence. And that's why even if your complete pituitary is gone, you will have enough vasopressin which is produced by those neurons that you will not develop diabetes insipidus. So when we talk about pituitary problems, we are largely talking about anterior pituitary. When we talk about posterior pituitary problems, these are actually problems above pituitary. There are problems which are happening at the level of pituitary stalk. There are problems which are happening at the level of hypothalamus. Therefore, the presence of DI. So, Nupur, in a child who has got diabetes insipidus with anterior pituitary hormone deficiency, do you think that lesion is at the level of the pituitary or it is above the pituitary? So this is a very important thing. So if your DI is there, if your prolactin level is high, you are not dealing with a pituitary lesion, you are dealing with a lesion which is above the pituitary. So these subtle things which we'll discuss. Of course, over the next 2 months or so, we'll be focusing about a lot of pituitary. So this is the basis about that we'll try to build up. So we all know that. So now if you look at the hypothalamic pituitary axis in terms of end organ, and this probably will be the most important part which we'll discuss as to how they interact with each other. So you have got GHRH, which controls growth hormone. There's also a somatostatin, but I'm talking more in terms of the important signal. GH works on the liver to produce IGF-1. Growth hormone will have a feedback inhibition. So all of them will have feedback inhibition. And IGF-1 will inhibit both growth hormone as well as the GHRH. So there will be a multiple level. TRH is regulating TSH, which is regulating T4 production. And there is an inhibitory effect at T4 to TSH, TSH to TRH. Dopamine is regulating the production of prolactin, which is an inhibitory signal. So what we are seeing, red line is inhibitory. So dopamine is only the single most important inhibitory signal which comes from the hypothalamus. Because you don't want everybody to lactate unnecessarily. No role in males, only in females for that particular period. So that's why it should be switched off. So if you look at, in certain scenario, you will see the default switch, like for AC and all is switched off. And sometimes you may have some fridge and all, they're always switched on because you need the fridge continuously, but you need the AC only when there is a problem in that regard. So dopamine is more like that emergency switch. When you need, you switch it off. Otherwise, we will inhibit it. Then CRH is controlling the ACTH, which is controlling the cortisol production. And cortisol is inhibiting, and we all talked about that in terms of regulation. There is a GnRH, which is regulating both LH as well as FSH, and this is regulating the production of the testosterone and estrogen. So very interestingly, the evolution is such that it does not want to waste things. It doesn't want to waste things. So that's why you got a single gonadotropin releasing hormone, and yet you have got two different types of gonadotropin which are controlled by the same hormone. So how is it that you have different LH and different FSH when you have the same hormone? No, why are the LH levels different? What else? So the pulse frequency decides the predominance. So if it's a slow pulse of GnRH, you have a FSH predominant response, that is hypothalamic amenorrhea, malnutrition, and pre-puberty. If you have a rapid pulses, you have a LH predominant response, which is puberty. Anything else? The half-life is different. The level of chelation, the post-structural modification decides the half-life. So LH will have a lower half-life, FSH will have a higher half-life. So that's why despite having a single regulator, you have got different levels of LH, FSH. Again, it's a new way of saving in terms of not having another. Otherwise, you need to create another hormone, so to speak, in that perspective. And then, of course, there is a AVP, which regulates the renal concentration and the urinary osmolarity. Now, this is a very simplistic picture, which is basically talking about how there is an interaction between single units, but this is not the real life world. In real life world, there will be crosstalks, the connects which will happen. So what really happens, and we'll talk about that a bit later, but before that, we have a 12-year-old boy with lethargy. There is central hypothyroidism, low FT4, low TSH, so TSH is less than 20, this is central. Cortisol is 44, so again, you have got a central adrenal insufficiency. Gonadotropin is low, so this is multiple pituitary hormone deficiency. So now, Nupur, which test will tell you this is pituitary versus hypothalamus? Yes, so if your prolactin level here is low, this is a pituitary lesion. So again, this is a fundamental thing, because if you have a transaction between the hypothalamus and the pituitary or a stalk lesion, everything will be low, but prolactin will go up. What is the level of this prolactin elevation usually, Manoj?
In the center.
No, in this transaction.
It will be not more than 100.
So 60 to 100 is the typical one that you will find in that regards. Now there are so many crosstalks which also happen, which are very, very relevant. A very important crosstalk is that of dopamine with TSH. Now, earlier, people used to say that there is a separate prolactin stimulating factor and a prolactin inhibitory factor. So, inhibitory factor they found was actually dopamine. And now it is known that dopamine also inhibits TSH. So, when dopamine inhibits TSH, the thyroid also says, okay, I'll also regulate something. The TRH will go, and this is going to increase prolactin level. So there is, in a way, you can say prolactin and thyroid are actually like cousins. The same thing increases both, the same thing inhibits both. So what is the relevance of dopamine inhibiting TSH? Dhwani?
So when a child is sick on inotropes.
So if you're on inotropes, your TSH will come down. So that is one thing. You can have a falsely misdiagnosis of hypothyroidism, which may happen. And the effect of TRH and prolactin, why is it important?
It's very high, and so TRH will also be high, and that can possibly.
So if you have anybody, so it will cause hyperprolactinemia. So primary hypothyroidism, high TSH, high TRH, high prolactin. Anybody with high prolactin, you also do a TSH. That is a big message. The other big thing which is regulating is the effect of prolactin on gonadotrophins. So prolactins, what will they do to gonadotrophins? Suppresses means what? Decreases what? It decreases the pulsatility of GnRH. And you said yourself that if the pulsatility is less, you have a FSH predominant response. So you will have hypogonadotropic hypogonadism. So anybody who has hypogonadotropic hypogonadism, prolactin becomes very, very relevant from that regards. And your LH FSH level will be there. Now, next important effect is the effect of AVP on ACTH. So what does AVP do to cortisol secretion? Manoj.
So, if body wants more fluid, then when osmolarity will increase, the AVP response has increased, and it causes the ACTH to secrete, and it will maintain the volume status.
So normally, if you say there are three major hormones which are regulating your volume sodium status or a fluid or a sodium status. One, you have AVP, which is basically causing free water to come in. You have got RAS, aldosterone, which is regulating your sodium. And you have got atrial natriuretic peptide, which is causing the loss in that perspective. If your osmolality goes up, you will have more AVP coming into the picture, free water more, it compensates for that. If your sodium is deficient, and sodium deficiency will come as volume, you will be volume depleted, you will have aldosterone which will keep up. But always remember there is a synergy. You will never depend on only one factor. So hypovolemia is also a stimulus of AVP secretion. So when you have hypovolemia, your AVP will go up. And when your AVP will go up, you also want to say, okay, whatever can help you, I want cortisol as well. So cortisol also increases free water. So AVP and cortisol become basically friends in this scenario, and they will increase. This has got huge implications. If you have a child who has got congenital adrenal hyperplasia, and you are giving inadequate mineralocorticoid, there will be a relative hypovolemia. That hypovolemia will increase AVP. What will be the treatment implications, Dhwani, in that regards? So, congenital adrenal hyperplasia, who has got inadequate mineralocorticoid coverage, causing hypovolemia, high AVP. How does it matter?
Yes, they are already sodium deficient, and plus they will have
anything else? So AVP is high, ACTH is high. So what will go up? Which metabolite will go up? Yes. So if you are monitoring control using 17-OHP, you will say his 17-OHP is high. What will you do? No. In a normal scenario, because you are intelligent, that's why you're thinking. Otherwise, everybody will say 17-OHP is high, let's increase glucocorticoid. But the problem is mineralocorticoid. If we increase mineralocorticoid, you will then say, okay, hypovolemia is gone, AVP is normal, your ACTH activity is not more, your 17-OHP is not high. So inadequate mineralocorticoid supplementation causes an increased 17-OHP. So in that scenario, which test will help you, whether it is a primary problem of mineralocorticoid or glucocorticoid? So plasma renin activity will help you out in that scenario. So this is an important parameter in that regard. So AVP is basically increasing cortisol. So what should cortisol do to AVP? So it's like a typical feedback. So as ACTH increases cortisol, cortisol inhibits ACTH. Same thing, cortisol is being increased by AVP. So cortisol is also going to inhibit AVP. Why is it relevant?
So, because when there is a cortisol deficiency, there is a SIDH like picture.
So if you have a cortisol deficiency, your AVP will go up. Once your AVP goes up, what are you happening? You have a SIDH like picture that will cause worsening of hyponatremia. And cortisol deficiency causes hyponatremia because of SIDH. Cortisol deficiency has nothing to do with mineralocorticoid action. So ACTH deficiency will cause hyponatremia because of that reason. Now, cortisol also inhibits TSH, and this is very relevant. So if you have somebody with Cushing syndrome, what will be the TSH level, Nupur? What do you think? In Cushing's, the TSH will be, you won't have hypothyroidism, but TSH may be low. So people may get confused. There is a central hypothyroidism in this patient, but that is because of the cortisol inhibiting the TSH. What will happen in adrenal insufficiency to the TSH?
You create the picture like hypothyroidism or subclinical.
So if you have marginally elevated TSH, just like in that case, you need to be first sure that you need to start treatment. Otherwise, you can wait and watch in that regards. And cortisol also inhibits growth hormone. So if you have Cushing syndrome and you do a growth hormone stimulation test, you will have a falsely negative, you will say it's a growth hormone deficiency. So you have to exclude hypothyroidism and Cushing syndrome before you really label somebody as, okay, this is growth hormone deficient. So 3-month-old child with developmental delay Vibha, TSH is 120, FT4 is low, thyroid scan shows dysharmonogenesis, but the neonatal screening, the TSH was not high. So what do you think could have caused the false positive result?
Positive
in the neonatal screening, he has hypothyroidism. So whether the patient was sick, whether there was preterm, admission, hydrocort, so all those factors. So this child actually was admitted, he was on dopamine, and this is the factor which Dhwani said can cause a deficiency in that regard. So you have to be aware about that. 10-year-old boy with weakness, there is a FT4 is nearly normal, TSH is 12, cortisol is low, ACTH is normal. So there is a cortisol deficiency which is there. There's a partially empty cella. You start hydrocort. What do you expect the TSH level to happen in some time, Nupur? So there is a mild elevation of TSH. So it may actually normalize. So then you may find that it is actually an interaction between cortisol and TSH. You don't need to treat. So it may be normal on follow-up. So you need to be aware about this scenario. Dr. Manoj, 16-year-old girl with menstrual irregularity, LH is low, FSH is low for the level of estrogen. So this looks like a hypogonadotropic hypogonadism. Prolactin is 120. MRI, hypothalamic pituitary is normal. What will you do?
Prolactin is inhibiting the LH synthesis. So
you will start cabergoline.
No, sir. It is yes, sir. Drug history.
Anything else? We are talking about, what are we talking about till now? So any, so you have to look at hypothyroidism also. That is also important. So one, of course, is a drug history, but you also have to look for hypothyroidism in that perspective. So there is an interaction of prolactin. Not necessary. Hyperplasia is a long-standing, very high. Often you will have normal this thing. So you may have to be careful. 15-year-old girl with primary amenorrhea, Dhwani, breast stage 1, pubic hair stage 2, height is 152. So this looks like a normal screening test. Every investigation is low. What will you do?
So is over pre-pubertal stage.
So this is delayed puberty, hypogonadotropic hypogonadism. Next investigation. What is the most important investigation in hypogonadism? Anything else? Thyroid, okay, but what else? You want to prolactin. So first you have to look at whether it is a hyperprolactinemia also in that regard. So prolactin is going to inhibit the LH-FSH level in this regards, and you have a prolactin secreting adenoma. We have many children who came to us with very early onset delayed puberty because of hyperprolactinemia. So it's not that only secondary amenorrhea will be because of hyperprolactinemia. If you have a lesion earlier also, you can have hyperprolactinemia as a cause. Vibha, again 14-year-old girl with delayed puberty, stage 2 breast, no pubic hair. LH is low, FSH is low, estradiol is 20. So what do you think is happening in that regards? Prolactin is 60. So MRI was planned. So again, as discussed, you have to think of TSH in that regard. So if you have hypogonadotropic hypogonadism, you look at prolactin. If you have hyperprolactinemia, look at TSH. So all anterior pituitary workup should be with together. 12-year-old boy with craniopharyngioma and Dr. Manoj, diagnosed 1 year back and surgery was done. Central diabetes insipidus on vasopressin, already on vasopressin, suddenly develops hyponatremia, and you have reducing AVP. What is the thing which might have happened?
So in this case, evolving cortisol deficiency, we have to think.
So there is a cortisol deficiency. That is why your free water excretion is impaired, and that's why you have got DI plus cortisol deficiency, which is more free water, less free water, and more free water. So this is going to minus it out. So that's why you're going to have a less AVP requirement. So cortisol is low. So if you have anybody whose AVP requirement is coming down in DI, insulin requirement is coming down in type 1 diabetes, antihypertensive requirement is coming down with hypertension, or calcitriol requirement is coming down in hypoparathyroidism, think of a evolving cortisol deficiency, and that could be life-threatening in that regard. So this is a recurrence of DI will happen once you start cortisol in that setting. Dhwani, 16-year-old girl with multiple pituitary hormone deficiency. She has received growth hormone on thyroxine and estrogen now, complains of lethargy and weakness. Cortisol is normal, and you did a synacthin stimulated also, it was normal. Now what happened that within a 15 days, she presented with shock and hyponatremia. So what do you think has happened? So clinically, she has cortisol deficiency, but your workup was all normal. So anything which could explain this? Look at the treatment.
Okay.
Estrogen. What will estrogen do? The cortisol binding probably, and make the estimation of total estradiol, total cortisol unreliable. So this is something you need to be aware of, that if you are treating with estradiol, you will have a confusion with regards to the cortisol level, and that may cause a problem in that setting. 4-year-old boy with MPHD, Vibha, thyroxine 50, started on GH25, FT4 has come down. Why? So he was otherwise fine. You started growth hormone, and then suddenly thyroid has become low. So what does growth hormone do to thyroid? So increase the inactivation of thyroxine. So that's why there is an inactivation of thyroxine. You may have unmasking of hypothyroidism, which may happen.